Let's dive right into it because value analysis is, I think it's a really fun topic. I think part of the reason I enjoy it so much is because it's really the beginnings of a clinically integrated supply chain. And that might mean a lot of things now, but when we were first attempting that, this is the business function of supply chain that began to bring clinicians, into the conversation and maybe bridge that gap. But I will say, the processes, it's all gotten a lot more sophisticated. And I think sometimes with that sophistication or just that evolution, is you start to see a lot of variance across different health systems in terms of who owns it, how do they manage it, what technologies do they deploy, and that's going to be really the basis of our conversation today. But I would really start with who owns value analysis today. Like when we think about governance, who is it in an organization, a high functioning organization, who owns value analysis, and how do you keep it from just becoming one of those really large committees that sometimes has people that don't need to be part of the committee and just making that work?
So value analysis is an integration of a lot of different modalities, a lot of membership. So it's not owned just by supply chain, it's not owned just by the organization, but it's a system-wide group. It's managed by finance, managed by supply chain, managed by your executive leadership, your clinical membership, your physicians, and at the same time, the ad hoc group that you have. One item that I would like to share in here is that it definitely would work together if you have just one platform to be able to enter every single request that would come through the health system. So there's proper tracking. So who owns it? It's everyone in the health system. It's a system-wide program, and it addresses the cost, quality, and outcome that the organization is trying to reach. So, what should organizations do? Typically, if there's no one group that actually is pulling it together, right now, my organization really directly aligns with the finance team. So, we report directly into our chief financial officer. However, we actually, in our value analysis committee, we report directly to our executive committee as well. So, they have the general oversight of what we do, but it's owned system wide by everybody.
I love that. I don't know that everybody reports into finance, but I can tell you, like, one of the questions I was thinking about asking you was, we're definitely going to talk about how to get clinicians engaged
Yeah.
and how to manage that and make that easier for them to be engaged. But I was going to say, before we even go there, is finance a team that is usually a little more difficult to keep engaged in value analysis? But I think you gave me my answer already, but I know you've been in this role in other places. Have you ever reported to finance in the past, and how engaged has finance been before the current structure that you're working in today?
Most of organizations use the value analysis as a supply entry. So typically, finance comes into view when it's time to look at, okay, let's look at our spend for the year. How did we do? So there's always the evaluation. However, engaging the finance early enough, they can actually advise on many fronts. One would be part is reviewing the pro forma that are being submitted into the health system, just to make sure that every program that is initiated in the health system aligns with the organizational goal. They can advise on capital reimbursement, and at the same time, the clinical, how do you charge the patient, or you're contracting with your commercial or the CMS or Medicare, Medicaid in that case. So involving them early enough would definitely be helpful for our program, because then part of your review, when you're reviewing a product, you need to have your product overview, and then you're going to have your clinical and quality and safety outcomes. And at the same time, your financial review, how does that line up with your contracts? Is it contractually feasible? Is the product in conflict with any other contracts that we already have in the health system? And then the financial part, the reimbursement part, would say, okay, this is how much we will be reimbursed for such particular DRG or diagnosis. So you'll have a better picture when you're making the decision. It's not up to me to make the decision for the committee. It's really up to them. So providing them every single necessity to make that decision, whether it's a yes or a no, before it goes to the executive committee, is key. So providing those quality outcome data and making sure that the physician, the requester or clinical sponsor can actually explain why do they need it, how are they going to utilize it, what is the benefit for the patient, and at the same time, what's the impact operationally within the health system.
Yeah. And I love that. And I think it's so critical to get finance involved early, but I just know that's sometimes a struggle. So that was just such a great answer. And I went off script, so just great job fielding one you weren't expecting. Let's talk about physicians and getting them to participate, and also, being a little like resistance sometimes occurs, and physicians, it might be their preference item that they are wanting to come into the organization, but then you have all of these different stakeholders that are going to be involved in that process, and you don't want to lose the engagement with the physician, but you can't say yes to everything necessarily. And so it feels like a fine line to walk sometimes. How do you navigate that successfully?
The way I view it is that physicians are not the barrier in approving a product or bringing in a product just because they want it. They actually are the solution to what the health system can offer for the masses, for the population that we serve. My organization and every organization I've worked with, we always say we are patient focused. So aligning those physicians into your value analysis process is key. One thing that we can do definitely when you're working with them is that they are very keen in looking at the clinical outcomes. You don't discuss dollars and cents right away. They're looking for what is the clinical outcomes for those the product that's being reviewed and what they're trying to bring. So part of their presentation is we ask them, why do you want to bring this particular product instead of utilizing what we already have on the shelf? So let them explain that process and then let them provide what would be the outcome that they're trying to come. So when we are reviewing a product, for example, a physician can actually guide them initially because I have communication with them beforehand. We give them the slide beforehand before the presentation so they know exactly what we're going to discuss. However, I also prep the product committee to really review the PCOTS process. Who's the patient? They need to start listening to who's the patient. What is the intervention that this product will do? C would be your what is the comparator? What product is being compared to this new product? And O would be your outcome. What outcome does this product do that the other ones cannot bring? So it could be like they are looking for a vessel sealer. Yes, we have vessel sealer for the other robots that we have. However, the one that they're requesting is something with a curve and tinier. They need to be able to go into the neuro part or maybe something that is an ENT product. So they need something that would curve better. Let them explain that. So providing quality outcomes, we also look at the mod data when we are doing value analysis process and again, the financial piece. So engaging them in a meaningful way, bringing them the clinical outcomes, let them show what this product can do and how it will support the programs of the organization are key in making sure that this is a successful implementation.
Yeah, what I really love about that is you're making yourself a resource to the physician by, curating the info, making everybody who might be meeting with the physician, making sure that they're informed and giving, accurate data. I mean, that's how you build trust with a physician. But if you can make their involvement as streamlined and efficient as possible, they're going to re-engage. If they feel like it's taking up a lot of their time or they don't have the information they need, you start to lose them. And I think that's, kind of what you were just describing is identifying the value in the product and being able to shape that as part of the evaluation.
Correct.
And understanding what the clinical need is that differentiates maybe from a like-to-like product that's already been contracted.
Yeah.
The thing that I'm super interested in is many times supply chain is looking for cost control.
Yeah.
And we still are looking for that. We're making sure that any, costs are sort of justified and have a clinical need. But a lot of times I think the perception is, oh, that's all they're trying to do is get us the lowest price and get us the lowest price. And that's not what value analysis is. And so how do we make it a true clinical discipline? And I think you gave some keys already, but I just want to expand on that if you don't mind.
Sure, I will do that. I left out a little bit on the physician engagement, for example. Our responsibility as leaders of the organization is really making sure that knowing the makeup of your physician pool. For example, how much percentage do you have of employed physician versus non-employed physician? Because that would definitely impact how you bring in the new product. Some physicians definitely, or groups definitely, would like to be aligned with what product that they are used to. However, involving the bioanalysis at the forefront, even at the physician onboarding, as raw as that, then we can have contracting be at the table and have a discussion at the same time for what we already currently have. It's not that they are hesitant in changing their processes in taking care of a patient. However, with proper training offering and at the same time bringing in support for them for additional training of the staff, definitely sometimes they're very, very much willing to change and align with you. So when you're looking at the cost control, let's go back to your the original question now. When you're looking at the cost control, you always have to keep the patient at the center of the decision.
Yeah.
So let me give you an example. Very recently, we were looking at implementing like a Z Flex. It's a heel boot elevator for the heel. And part of that is the product is a little bit expensive when you say that you're trying to protect the heel of a patient as compared to what we already have in the system. However, bringing in that product, keeping the patient at the center of what you do, and looking at your quality currently right now, your happy HAPI data for pressure ulcer injuries, we notice in our tracking that we are definitely um, very much above the national benchmark. The national benchmark is about 16. And I'm afraid to say that, yes, we are at 26. However, we've implemented such process because now we can align with we know the baseline of where we are. Introducing this new product, then we will be able to really look at what's our next step. Did it work for our implementation? Did our investment work for the cost, quality, and outcome that we're trying to reach? So, keeping the patient in mind first, the money will come. However, you have to take care of the patient first. And that's part of taking care of you, taking care of your patients, and therefore taking care of the community at the same time.
I was totally just going to say, it's a community service, right? It's the
Oh,
people
there you
that
go.
you
We're reading each other.
live and work with.
What can I
Yeah,
say?
you and I see things through a similar lens because
Yes,
it was immediately what I thought when you said take care of the patient. I was like, and take care of the community by extension, which,
yes.
is so important. I want to shift to vendors, and what I mean is they have the product information. When you're doing the data gathering, you're going to need to engage the vendor to some degree, and at the same time, you want to make sure that the decision integrity is in place. You
Yep.
want to make sure that you have the right controls. So if you're talking to a vendor today and saying, this is how you can support our value analysis process without crossing some lines per se,
Huh?
how do you do that? What would you recommend? I'm sure there's technologies that can control some of the data gathering, but I think there's more to it.
Okay, let me talk to our vendor partners that are in here. We call them industry partners for a reason. So they're not just vendors to us, they are industry partners. We cannot do our work without them. So part of a product review is definitely having the information available, maybe qualitative and quantitative data, pricing definitely, as well as support, educational support. We need that. Engaging with our industry partner is not just stating, okay, we need this and we need that. We need to provide some sort of a guardrail when working with them. So let us not don't let your vendor or industry partner define. Um, they should not insist on a decision or move you in a pathway that can influence the decision of the committee. So One of those processes is really removing them from any of the clinical discussion, aside from when you need to pull them in for that particular discussion, especially during the beginning when you're trying to look at the new product, for example, and actually pulling additional information. However, you need to really dig as value analysis healthcare professional. You need to verify the information that's presented to you. You have to trust, but you need to verify. That's what I've learned
Yeah.
from my previous mentors. They said you have to trust, but you have to verify and make sure. So they should not define the clinical need for us. They should not also drive the decision, and they should not be the only sole source of information for us. So based on my conversation with them, every single product that comes through my organization right now is that I have a one-on-one. If a product is questionable, for example, I have a one-on-one with the vendor and let them explain to me what is so special about this new technology that they're trying to bring in. What is so special about pricing, and what are the techniques for reimbursement, for example. I'm giving them the chance to be able to show them the product because right now they probably hadn't spoken with the clinicians, and sometimes I'm removed from that discussion point. However, the feedback that I receive when I do one on one with them is that they are very thankful that they were able to share the information in a deep dive, and building that relationship with them would make it a lot easier when it's time that you have a product disruption down the line, or you need a new product and they are the only manufacturer that can substitute a product that's on product disruption. It makes it a lot more functional and relational when you're trying to be able to build that relationship with them from the get-go, and building it is a key.
Yeah, it's interesting. The product might not be approved, but then you're getting information, like you said, in the event of disruption, and they might be the first call
Correct.
if that happens, especially if you have a good experience. So I do want to call that out. I think that was a
Yes.
really important point. Um, let's talk about when value analysis programs don't work. You know,
Okay.
what are some common reasons that those programs start to fall apart, even if they're set up well initially and
Mhm.
everything seems
Yeah.
running perfect? Like at some point, you know, through turnover, time, adapting the process, lots of different reasons they could fall apart. What's the usual causes?
Typically, when you're looking at the processes and you look back and you look at the remnants of why did this project didn't go through, or why did it fall through, and what did we do wrong. Typically, it's not in the strategy portion. It's more on the implementation phase. So when I say it's implementation phase, there's no strong process on um, governance in looking at those one-off or emergency request approval that they actually just flow through the system for you. There's so many of those that no one is actually watching all those submissions into the value analysis process. So now you have so many products out there and you don't know which one is which are already approved. So when there is one strong process from entry to evaluation to due diligence to look at your key performance indicators and your outcome down the line would definitely make you stronger throughout that process. So defining it is key, so that way you don't have a failure system that you need to recover afterwards. Um, it's also significant that every single member of your committee is in tune, your clinicians are in tune, and at the same time, your leadership are actually informed of the processes that you have in place, so that way they can advocate for you at the same time.
Yeah, I'm just thinking about keeping a pulse on sentiment amongst people that you're engaging in the process is probably really important.
Yes, absolutely. You're trying to deliver value. So the value is, of course, what are those the quality outcome that you already have over the cost. Cost is yes, it's a cost is the bottom line for everything. However, there are a lot of different other factors like when you integrate your the Association for Healthcare Value Analysis pillars. They look at your governance, they look at your methodology. We're also looking at ethical practice. And at the same time, we're looking at the finance review. So those are the pillars that we work with, and bringing in the industry standard process of value analysis within the organization is key for success.
Yeah. So with that, you're teeing up my next question beautifully. I feel like you should be a host. Like you could run one of these very easily.
Do better.
That process, you're talking about the bones of the structure, like all the key pillars, right? But now let's just go a little bit, fly a little bit lower to the ground, get a little more detail around what a clean, reliable process really looks like, from when the product comes in to when it's either approved or not approved, and keeping it moving along. Because I think one of the things is people submit, product requests, and then they sometimes just sit. And for the rate of change that's required in healthcare today, we have to move these to decision fairly quickly, not speed it up and skip the diligence. But we need to find where the bottlenecks are. We need to remove them, and we need to get to the decision as quickly as possible. So what's the cleanest, most reliable way to do that? What should that process look like?
So when you're looking at your entire value analysis to make sure that it is clear and transparent, you want to make sure that it is actually properly vetted within. And one of them is looking at your current metrics. When you're looking at your metrics clearly, you just do not talk about just straight savings. That's how you lose credibility with your clinicians and your stakeholders when you just start talking about finance and money savings. So you need to really integrate your other metrics that were you looking at. Clinical outcomes, you need to do to see the before and the outcome afterwards and be able to track that. Your utilization and the variations of use. That's important as well. And adoption and compliance. And the other time is time to the decision. It has to be fast. So there is actually like a complexity scoring that you need to make sure that it's implemented within the bioanalysis process. So when you say there are three levels of complexity, the first level, and this is according to the Association for Healthcare Value Analysis Professionals and adopted by many GPOs as well. The level one category would be your commodity items, like your pitcher, for example, your band aids, your tissues, and so many other things, minor things. That should not take more than 30 days to approve and review and approve. Second level, these are your clinically indicated items like your IV catheters, for example, Foley catheters. That should not take more than 60 days to be able to review and approve or flow through the entire process, as I mentioned earlier. Category three are regulatory related. So we heard from Don Hall earlier from Joint Commission that you must have a very strong governance to be able to do this. And thank you for her insight and her guidelines from Joint Commission on that process. Because then category three is related to regulatory items, and that would take, or maybe a programmatic implementation of a cardiac program or rehab program. So that takes a lot, maybe 90 days to be able to implement that whole entire process from review all the way to the final decision whether we will adopt it or not. When you have every single step aligned, it makes it a lot easier to understand what type of product is being brought in, what decisions we need to make, which metrics do we need to make or pull, and at the same time, which governance structure, who else are the ad hoc members we need to pull in this discussion point. It could be that IT will be very much embedded. EDS, for example, risk management would be necessary, or maybe your biomed department. So it makes it a lot clearer for you to be able to show the trust factor, because then you are touching every single point that sometimes a lot of people within the organization doesn't think about. But value
Yeah.
analysis is there to support that whole entire process.
Yeah, I think just that visibility to the stakeholders, and who should be involved and where they're at in their evaluation, all of that
Yeah.
is very important. And coordinating, because it's, again, like you said, everybody is sort of involved, but somebody's got to help manage that the process is moving along. I love all the pointers
Let
that you
me give
had
you an
there.
example. Just this morning, I was requested to review It was an exoskeleton used to support a patient to get up from the rehab standpoint. And so they were asking guidance on how they would like to bring the product in. Can they trial it? They already did. They say, the vendor already came and did a demo and we love it. We would like to have it. Oh, sure, definitely. You would like to bring it in. However, the guidelines that I was able to provide this group is that, okay, let's take a look at this as it's a new program within the rehab department. That is a service line request to move forward to be able to support what the organizational goal is for the whole entire rehab department. So there's an internal review within the rehab department whether they can support it or not. If there are any products, I did say that if there's any disposable items that needed for this particular product, we'd be happy to review that in the product review process. However, it's initiated within the service line, requesting at the whole entire picture of how they would like to deliver the care and improve the care within the service line and move it up to the next level for approval. And then that can be broken down. It could be an EPMO request or something bigger, but it will involve a high level decision making process, and it involves your executive level and service line view of how we would like to funnel this through the organization.
Yeah. Dr. Lurie, this has been an amazing conversation. We didn't quite get to the metrics question, but I will tell you what, you brought so much value to everybody tuning in today. And you can just see like the audience is giving you a lot of applause, and rightfully so. It's great to spend some time with you again. We'll have to get connected again soon. And I just want to thank you for contributing your insights and, sharing what you know to be effective ways of, developing a program that's sustainable and can have impact on an organization. My biggest takeaway is that you report to finance. I just find that so amazing and interesting. And so I think sometimes people just need to know that there isn't one right way to structure things. You have to structure them the way that it makes sense for you, for your organization. And I love how creative you've gotten with that to, really have that impact. So Dr. Lurie, thank you again.